Hello, everyone. This is Dr. Mickey recording a lecture on chapter 25. So it's the drugs for fluid balance, electrolyte, and APGs or acid-base disorders, and the analysis or interpretation of the arterial blood gases. So the water content of the body, it's present in three main compartments. The first one is the main compartment, which is intracellular fluid, ICF. The second is the extracellular fluid, which is ECF, and which is the fluid in the ECF is present in two subclasses or subcompartments. The first one, in the blood vessels, which is the plasma or the intravascular space, and the other component of the extracellular fluid will be in the interstitial space. So the extracellular fluids are either in the blood vessels or the interstitial space. And then we have the third smallest volume of fluids will be in the transcellular compartment. Now, the majority of the body weight in infants, about 70 up to 80% of their body weight is fluids. And contrary to this, or opposite to the infants, will be the older adults, in which that the fluids accounts for 45 up to 55% of their body weight. Then as we move on to explain about the fluids in each of these compartments, we will find that the about 2/3 of the body water are present in the ICF, inside the cells, intracellular fluid. And most of the cations in the intracellular fluid inside the cells would be the potassium. So potassium is the main intracellular cation inside the cells. Now, outside of the cells, extracellular fluid outside the cells are present, we said, either in the blood vessels or interstitial space. So out of the body weight, about 20% of the fluids are outside of the cells, extracellular fluid, in which about 15% of the ECF of that 20%, 15% will be in the interstitial space, and about 5%, only 5% will be in the plasma, or in other words, we can say it's the vascular volume or the intravascular space. 50% of that 20% of ECF are present in the blood vessels, and 50% in the interstitial space. So, and the most prevalent cation in the extracellular fluids in the interstitial space would be the sodium. So potassium inside the cells, sodium outside the cells. However, the transcellular fluid, the smallest volume of the smallest compartment of these compartments, and the smallest amount of fluids in this transcellular space or compartment accounts for about 1,000 ml, with this 1 liter fluid. And the fluid will be present in all of these places, like the CSF, cerebrospinal fluid, the GI tract, fluids in the pleural space around the lungs, between the pleural space and parietal space, or lining around the lungs, small amount, in the joints, synovial fluids, in the abdomen as peritoneal fluid as well. So these are the 4 or 5 main places in which the transcellular fluids will be present, and accounts for very small percentage of the body weight. It's about 1,000 ml total. Now, let's go over now the forces that govern the fluid movement or shifting between these compartments. And when there is a homeostasis, which means that these forces that govern the shifting of the fluids between compartments are in harmony, in homeostasis, and they are in balance, and they are that's a healthy status. And that's what is called the first spacing. In other words, that it's the normal distribution of fluids within the in these compartments. So the mechanisms that are going to control the shifting of the fluid between the compartments and maintain the homeostasis are osmosis, diffusion, facilitated diffusion, active transport, hydrostatic pressure, and oncotic pressure. Now, the osmosis, which is the movement of water between two compartments by a membrane permeable to water but not to a solute or the particles or substance or molecule. So the water moves from area of low osmolality, in which there is low solute molecules, concentration. So the water will move from the area of low osmolality or low molecule concentration to area of high solute concentration. However, the diffusion, which is the movement of the solute from an area of high concentration to low concentration. So the area of high concentration, which will have high molecules, high solute. So the diffusion occurs in liquids, solids, and gases. So the membrane separating the two areas must be permeable to substance for diffusion to occur. So for that diffusion, for that to allow these molecules to move across or against that membrane, this membrane has to be permeable to these substances or these molecules. Otherwise, these molecules will be trapped in that compartment, unable to move to the other side. Now, the facilitated diffusion, which is the specific carrier molecules involved to accelerate diffusion. An example of this one would be the movement of glucose molecules into the cells, in which the insulin molecule is going to assist these glucose molecules to enter the cells. The active transport, which is process in which molecules move against concentration gradient. In other words, that this requires the expenditure of energy to allow these or to allow these molecules or material to cross the membrane. An example of this one would be the potassium or sodium potassium pump. Sodium potassium pump requires a source of energy, which is the ATP, adenosine triphosphate, as a source of energy to maintain or keep that pump working and active and functioning. So in the absence of the ATP, that pump will fail. The function of that pump during the homeostasis, it maintains more of the potassium inside the cells and more of sodium outside of the cells. However, when this pump fails in the absence of the ATP as a source of energy, the pump fails and then more sodium will enter the cell and will be followed by the water, and that will result in swelling of the cell, and that is that will result or yields to the death of the cell because it will burst from the excessive amount of water that will enter the cell. The bottom side of this slide shows the difference between hypotonic solution, isotonic solution, and hypertonic solution. Hypotonic solution is going to allow in which the solute concentration is greater inside the cell. So more solute, more molecules inside the cell. So the free water concentration is greater outside. So we have more water outside of the cell because we have less solute, less molecules. So this will allow, so in other words, that we have more concentration inside the cells more than outside the cells. So because of that, more water is going to flow from outside the cells into inside the cells or into the cells. So we're moved from out to in, from outside to inside the cells. The water moved because we have more concentration inside the cells more than outside. To make that balance, to reach that homeostasis, and make both sides or both compartments inside the cells and outside the cells same concentration, water has to move inside the cells. So that's the hypotonic solution. When you have hypotonic solution, you're allowing more fluid to move from the plasma to move to go to enter the cells. So out of the plasma, out of the blood vessels, into the cells. Isotonic, that's going to have both directions. In other words, that the concentration of inside and outside are exactly the same. So that will result in the flow of the water or the fluid going to flow in and out in an equal rate. So that will result, because that will result, lead to or yield to a consistent concentration, or exactly the same concentration outside to as well as inside the cells, because that's isotonic solution. So isotonic solution doesn't affect the water movement, or in other words, does not expand the vascular volume. However, if you want to expand the vascular volume and make the fluid or the water to enter the cells, sorry, the blood vessels or the plasma, you are going to pull water from the cells inside the blood vessels by the hypertonic solution. Because hypertonic solution, you have more concentration now in the blood vessels than what's inside the cells. So when you have more concentration inside the blood vessels, vascular volume, then you are allowing for fluid to move from the cells, inside the cells, out to go to the blood vessels. So the free water concentration is greater inside. In other words, the more fluids are inside, inside the cells, so they are going to flow outside the cells, going to enter the vascular volume. This is an example of when you administer the hypertonic solution, you're allowing for fluid to be pulled from the cell to get into the plasma or blood vessels. Osmosis, again, that's the movement of water from an area of low concentration to area of high concentration, or osmolality. Hypertonic, intravenous fluid, water moves from interstitial space to plasma. We said the fluid in the previous slide, we said the fluid are going to move from the cells to the plasma, but actually it's going to be moved from the interstitial space, which is the same concept, that the flow is going to be pulled into the plasma or vascular volume, but from the cells and interstitial space. Hypotonic IV fluid, in which the water going to move from the plasma, because that's where the flow is going to be administered, hypertonic, into the blood vessels, so the blood vessels will have a low osmolality, so flow is going to move from that low osmolality to the interstitial space, the other way, from blood vessels to the interstitial space or to the cells. There is no fluid shifting when you administer the isotonic solution or IV fluid. Yeah, osmotic pressure. Determined by concentration of solute or molecules or in the solution. Water move from less concentrated to more concentrated side. The hydrostatic, in which the force within the fluid compartment, so the hydrostatic pressure is exerted from the force within the fluid compartment, from the volume itself. And that's the major force that would push the fluids or water out of the vascular volume or system at capillary level. The oncotic pressure or colloidal pressure, that's the osmotic pressure exerted by colloids or proteins or albumin in solution. And that will maintain the intravascular volume by pulling the water from the interstitial space back into the capillaries, blood vessels. And the protein, including the albumin, prealbumin, all different types of proteins, they are the major colloid in the vascular system that will maintain the fluid within the vascular system because they're going to pull the water into the blood vessels. The osmolality, which measures the osmotic pressure, which is the concentration of the solute or molecules per unit of weight of solvent. So the concentration of osmotic pressure, which is a lab value, it's dependent on the number of dissolved solutes in 1 kilogram or 1 liter of fluid. And usually sodium, glucose, urea. These are the dissolved solutes in the fluid, which is sodium, glucose, and urea. Approximately the same in various body fluid spaces. That osmolality is going to be pretty much approximately the same in different or various body fluid spaces. Now, when we say tonicity is the ability of a solution to cause change in water movement and across the membrane due to the osmotic forces. The normal value of the osmolality in the blood ranges from 275 up to 295. So when the plasma osmolality drops lower than 275, which means the plasma is diluted, which means that there is a lot of water there. So it's an indication of water excess or water overload. But when the plasma is concentrated and the osmolality is over or exceeds 295, that's which means that the plasma is concentrated, a lot of solute, a lot of particles, molecules, and we have less water. So that indicates there is a water deficit. The four main forces that govern the movement of fluids between compartments are the capillary hydrostatic pressure, plasma oncotic pressure, interstitial hydrostatic, and interstitial oncotic. The regulation of water balance are regulated by four major hormonal or endocrine and non-endocrine organs, like, for example, hypothalamic regulation. The osmoreceptors in the hypothalamus will sense the fluid's deficit or increase in plasma osmolality. It stimulates thirst and antidiuretic hormone release. It will result in increased free water and decreased plasma osmolality. The pituitary regulation under the control of hypothalamus, the posterior lobe of the pituitary gland releases the ADH hormone. Stress, nausea, nicotine, and morphine are they usually stimulate the ADH hormone release. Adrenal cortical regulation. The adrenal cortex releases hormones to regulate water and electrolytes, such as glucocorticoid, cortisol, and mineralocorticoids, which is aldosterone. And the aldosterone is a mineralocorticoid with very strong, potent sodium retaining and potassium excreting capacity. In other words, patients with high aldosterone, they tend to develop a hypernatremia and hypokalemia because the aldosterone, its function is to pull back or to retain sodium, reabsorb sodium, retain sodium and fluid, and excrete potassium. So patients with high aldosterone, they tend to have more sodium, more fluid overloads, hypernatremia, and less sodium in the bloods, which is hypokalemia. Renal regulation. Kidneys are primary organs for regulating fluid electrolyte balance through the excretion of electrolyte, sodium and potassium, mainly. Renal tubules are sites of action of ADH and aldosterone. That's where the ADH and aldosterone, they mainly function, or the site of action of these two hormones are on the renal tubules. And also the renal or kidneys regulation through the selective reabsorption of water and electrolytes. There is also a cardiac regulation for the fluids, because we have an ANF, which is atrial natriuretic factor, which is a hormone released by the cardiac atrium in response to increased atrial pressure. So when there is an increased atrial pressure, increased atrial volume, like in CHF, for example, you'll find more or an elevation of the ANF, atrial natriuretic factor. So the ANF causes the atrial natriuretic factor causes vasodilatation and increased urinary excretion of sodium and water, and eventually decreases the fluid of the blood volume. Now, the gastrointestinal regulation, GI regulation. The GI tract accounts for most of the fluid or water intake. Small amounts of water will be excreted or eliminated by the GI tract and the bowel movement or in the feces. The insensible water loss, which is invisible vaporization from the lungs through perspiration or sweating through the skin. So excessive sweating, not insensible loss, leads to loss of water and electrolytes. The fluid balance and exchange. The extracellular fluid transports nutrients and oxygen to cells and carries away, will take away these waste products or for elimination. So the causes of fluid shift out of the blood vessels. Now the fluid is going to mean, to move out of the blood vessels to the interstitial space. In other words, that the edema or swelling will develop. So that will result either from the elevation of venous hydrostatic pressure, decrease in plasma oncotic pressure, or elevation of interstitial oncotic pressure. And the elevation of the hydrostatic pressure, which is, for example, like CHF, liver failure, liver cirrhosis, obstruction of venous return to the heart, like when there is a tourniquet, restrictive clothing, or a tight bandage, or very tight dressing, especially circumferential dressing, venous insufficiency, like in varicose veins, that will increase the hydrostatic pressure. Now, the decrease in plasma oncotic pressure, that such as like patients with renal disorders or renal or kidney disease, because they will have excessive protein loss, and when the protein is lost, the fluid will follow. That will result in excessive fluid shifting out of the blood vessels into the interstitial space. Because remember that colloidal proteins, colloidal pressure, oncotic pressure pulls the fluid into the vascular volume or vascular space. Kidneys result in protein loss from the blood vessels, which leads to fluid fluid shifted from the blood vessels to the interstitial space, which result in edema. Also liver disease, because that will result in deficient protein synthesis. Also patients with malnutrition, because that will result in deficient protein intake. The third one, which is the elevation of the interstitial oncotic pressure, and that will result when patients develop trauma, burns, inflammation, which may damage capillary walls and will allow plasma proteins to accumulate in the interstitium or interstitial space. So more protein will be in the interstitial space, which will pull fluids from the vascular volume or vascular space. The interstitial fluid moving back to the plasma. There are two main forces. The first one, the elevation of the interstitial hydrostatic pressure, and it has a therapeutic effect, which is an example of this one would be when someone wears elastic stockings or the compression stocking devices, the TED stockings, in which that the fluid, the stockings or this application will put some pressure on the blood vessels on the interstitial space to push the fluid out of the interstitial back to the plasma or blood vessels. So that's an elevation of the interstitial pressure, hydrostatic pressure, by applying the TED stockings. It's direct pressure on the interstitial space to allow fluids to be pushed back to the blood vessels. The second example of that fluid being pushed from the interstitial back to the plasma or blood vessels, due to the increase the force that would result in that movement is the increase in the plasma osmotic or oncotic pressure. So when the oncotic pressure in the plasma increases, that will result in, like, when you give some or administer colloids, proteins, albumins, dextran, mannitol, or a hypertonic solution, you are going to pull more fluids from the interstitial space back into the plasma or to the vascular volume. So an increase in the plasma osmotic or oncotic pressure will result in more fluid being pulled from the interstitial space into back to the plasma or vascular volume, such as administration of colloids, proteins, albumins, dextran, mannitol, or administration of hypertonic solution. The spacing, the three different types of spacing, we said the first spacing, which is normal distribution of fluids among between all the three different compartments, ICF, ECF, transcellular. However, the second spacing, which is the abnormal accumulation of fluids in the interstitial space. An example of this one would be edema, swelling, CHF, patients with varicose veins and have acne, pulled, or stagnation of blood in the lower extremities due to the incompetent valves in the veins of lower extremities. This is or patients with low albumin, hypoalbuminemia, or hypoproteinemia. That's low protein in the plasma will allow fluids to leak or exit the blood vessels, results in second spacing, which is the edema or swelling. So the third spacing, in which that the fluid is going to accumulate but will be trapped in a body part that's in which it's difficult to be treated with traditional classic diuretics. Like you can't just give furosemide or spironolactone or any other, or Demodex or any diuretic that's going to resolve this problem. An example of this one would be like ascites, for example, which is accumulation of fluids in the peritoneal cavity. So when the fluids accumulate in the peritoneal cavity as ascites, the diuretics, they have a very minimal effect on the movement of the fluid out of the abdomen or the peritoneum. The only effective or the most effective therapeutic modality to move the fluids is to aspirate them, is to be aspirated because they are trapped in the peritoneum, and it's not going to be exchanged with with another compartment like intracellular, like it's going to be pushed like to the cells or back to the bloodstream, blood vessels. That only way, because they're trapped in that compartment, then we have to mechanically remove them through the aspiration, like paracentesis for ascites, pleural effusion, fluids around the lungs. We have to do that, or the most effective modality is to aspirate that or to remove it through or by the technique called thoracentesis, aspiration of the fluids from the synovial fluid in the joints, or that's also the aspiration of the fluid from the joints. So third spacing, the mechanical removal is the most effective therapeutic modality for third spacing because the fluids are trapped in that compartment and is not going to be exchanged with other compartments. Hypovolemia. So we treat hypovolemia with crystalloids, IV solutions with electrolytes. The hypovolemia, the etiology of hypovolemia can result from loss of normal body fluids, like due to diarrhea, acute or chronic hemorrhage or bleeding, perspiration, especially profuse perspiration and sweating, excessive diuresis, like patients with hyperglycemia, like a DKA or HHNKS, the two different types of diabetes, complications from diabetes, or patients with DI, diabetes insipidus, in which there is a deficiency in the production of the ADH hormone, or sometimes for the hypovolemia will result from the decreased fluid intake, or the fluid shifting from the plasma to the interstitial space, like in burn cases. Laxatives sometimes result in hypovolemia. Suctioning, NG tube suctioning, PEG tube suctioning, right type of suctioning, or even patients with fistula, because the fistula will lead to excessive loss of body fluids and secretions through the fistula, or ketoacidosis, in which what we mentioned earlier, DKA. Now, the deficient fluid balance disorders can cause dehydration, and the potential complication is the hypovolemic shock. To treat hypovolemia, you can treat it with either oral or IV fluids, PO or IV. You need to give the balanced IV solutions based on the type of hypovolemia, and it can be isotonic, or sometimes we have to give blood transfusions. The colloid solutions, which are the molecules too large to easily cross the capillary membrane, so they will stay in the intravascular space, rapidly expand the plasma volume. They will draw water from the intracellular fluid and from the interstitial space into the plasma space. So it will increase the osmotic pressure in the plasma. So these are called plasma expanders. So for an example, this will dextran 40, for example. The dextran is a plasma expander, plasma volume expander. It's a colloid. And the plasma expanders, they stay in the vascular space in the blood vessels and increase the osmotic pressure. The plasma expanders, they include colloids, dextran, and they are protein solutions, albumin as well. Another example is albumin, and they are available as, like albumin is available as 5% and 25% solution. So the dextran is a polysaccharide that is too large to pass through the capillary walls, and the dextran is given as an IV infusion, and it has the capability of expanding the plasma volume within minutes after administration. The cardiovascular responses include increased blood pressure. So when you give dextran, you anticipate expansion of the blood plasma volume, which will result in increased blood pressure, increased cardiac output, and improved venous return to the heart. And the dextran 40 is usually excreted rapidly by the kidneys. What are the indications for dextran? What would you prescribe dextran? Dextran will be indicated for fluid replacement for patients experiencing hypovolemic shock due to the hemorrhage, surgery, or severe burns. So when it's given for the acute hypovolemic shock, it is infused as rapidly as possible until the blood volume is restored. An emergency administration of maybe given 1.2 to 2.4 grams per minute, but in the non-emergency, administration should be infused no faster than 240 milligrams per minute. Adverse effects: a small percentage of patients are allergic to dextran 40, including the possibility of the anaphylaxis. If that's the case, the drug should be discontinued immediately if signs of hypersensitivity are suspected. So we don't recommend giving dextran, so it's contraindicated in patients or for patients with acute kidney injury or severe dehydration, or patients with severe heart failure, patients with hypervolemic disorders. Hypervolemia, fluid excess. It may result from excessive fluid intake, abnormal retention of fluids like heart failure, or interstitial to plasma fluid shifting. Treatment of the hypervolemia is through either administering the diuretics, fluid restriction, sodium restriction, or the potential complications of the hypervolemia or fluid excess would be, or fluid overload, as pulmonary edema and ascites. Now, electrolytes. The electrolytes, the schematic drawing of electrolytes will be this type of drawing or schematic drawing, in which you have all electrolytes in one drawing, and easily, you can easily visualize and review all the electrolytes using this model. So the cations we are going to highlight in this chapter are sodium, potassium, and calcium, and the anions, bicarb, chloride, and proteins. The sodium, which is the essential to maintain osmolality, water balance, and ABGs or acid-base balance. And these are the forces that govern the sodium and water regulation. We mentioned some of these factors earlier. Sodium is necessary for ECF volume and concentration to maintain the normal distribution of fluids and between the ACF and between the ECF concentration and volume. Generation and transmission of nerve impulses, that explains also why would patients with hyponatremia or hypernatremia exhibit neurologic symptoms and manifestation, including coma. And also it's necessary for the acid-base balance. The hypernatremia, sodium over 145. What causes hyperosmolality? It's a hypernatremia will result in hyperosmolality. So it will draw fluids from the interstitial space and cells into the plasma volume or vascular volume and will result in cellular dehydration because we are pulling fluid from the cells and interstitial space into the plasma volume or space. Pulling the fluid from the cells and the interstitial space into the plasma will result in cellular dehydration. The primary protection is first from the signal that's going to be activated by the hypothalamus, because there are sensors that are going to result in that, we will feel that thirst, and that will prompt us to drink that fluid to correct this hypernatremia. Most commonly caused by kidney disease. So the sodium accumulates and result in decreased excretion, high net water loss, or high doses of corticosteroids or estrogen. So what makes the sodium to accumulate and result in hypernatremia? It's either because of the decreased excretion by the kidneys, and they are going to be retained and accumulate in the blood vessels. So decreased excretion by the kidneys, or high net water loss, like when the patient has a watery diarrhea, fever, burns. And the third one would make the sodium to accumulate is the high doses of steroid or estrogen, because the side effect of estrogen or steroids is the sodium retention. The hypernatremia manifestations. Thirst, fatigue, weakness, muscle twitching, neurological changes like being lethargic, agitation, seizures, coma. The convulsions, altered mental status, AMS, decreased level of consciousness. And it can be produced by diabetes insipidus and the increased insensible water loss or perspiration. So the management is to treat the underlying cause. So and also can be treated with low salt diet, the acute hypernatremia treated with hypotonic IV solution. If hypovolemic, like hypernatremic, but with hypovolemia, then you will treat that with hypotonic solution. If the patient has hypernatremia and hypervolemia, then should be treated with diuretics. Sodium or serum sodium levels must be reduced gradually to avoid cerebral edema. Hyponatremia. Causes of hyponatremia caused by excessive dilution of plasma, excess of the ADH hormone secretion, excessive administration of hypotonic IV solution, and sometimes the hyponatremia will result from using the diuretics combined with low sodium diet, because especially diuretics, the sodium any type of diuretic, because we're losing water and sodium. If the patient is not eating or at least having a balanced sodium, at least 2 grams of sodium daily allowance, that would result in hyponatremia. Or patient who has losing fluid through the GI tract, like diarrhea, vomiting, and tube suctioning or peg tube suctioning, excessive water drainage, in which that there is a large wound and results in fluids or secretions being lost through the and sodium would be lost through the wound, or patient with a fistula, like enteric fistula or intracutaneous fistula, in which that there is a channel passage between the GI tract and the skin, and the fluid and secretions are going to be lost through the fistula, which results in excessive loss of secretions and fluids and sodium. That can result in hyponatremia. The manifestations of hyponatremia: in the early symptoms, patient may have nausea, vomiting, anorexia, abdominal cramping. And the late signs or the later signs would be having altered mental status or altered neurological function, like confusion, being lethargic, convulsions, seizures, coma, muscle twitching, tremors. To manage hyponatremia, if caused by water loss, then hyponatremia caused by excessive dilution, you can treat that with the fluid restriction, treat that with giving loop diuretics to cause an isotonic diuresis. So that's for the hyponatremia has been resulted or caused by the excessive dilution. So we have to restrict fluids or give loop diuretics that will lead to a balance or to the homeostasis or normal sodium concentration with the fluid volume. But if associated with abnormal sodium loss due to the fluid loss, then treat that with fluid replacement with sodium-containing solutions, like NUR268 or lactate ringer solution. Now, in cases of patients who had developed severe symptoms due to hyponatremia, like seizures, convulsions, then a small amount of IV hypertonic solution, like 3% normal saline, should be administered. The sodium chloride usually is administered or prescribed for hyponatremia as an electrolyte. So when the serum sodium falls below 115, a highly concentrated solution may be infused. So less than 115 sodium level, then we have to administer a high concentrated normal sodium chloride, like 9% sodium chloride should be infused. Under indications, so this drug should not be administered to patients with hypernatremia, patients with heart failure, or impaired kidney function. Treatment of overdose if fluid accumulation occurs due to the excessive sodium, then the diuretics may be administered to reduce the pulmonary or peripheral edema. Potassium. Potassium is important for the transmission and conduction of nerve impulses, for the maintenance of normal cardiac rhythms, for the skeletal muscle contraction, and for the acid-base balance. Now, the regulation of potassium is influenced by aldosterone. In which we said that the aldosterone function to retain sodium and water and to allow the excretion of potassium through the kidneys and urine. Sources of potassium. We get the potassium from fruits and vegetables, mostly like, banana and oranges, and then from the salt substitutes from the when patients receive, potassium medications like the PO tablets or IV solution of potassium, and also potassium will be in the stored blood. So that will patients with, for example, who with severe anemia will receive multiple blood transfusions, and because the potassium is the intracellular cation, so it will be inside the RBCs, inside the cells. So when these cells burst and break down, these cells result in the release of the potassium in the plasma, and the patients develop the hyperkalemia due to that. Potassium is supposed to be between or in the plasma 3.5 up to 5.0. Causes of the increased retention of potassium, either kidneys failed to excrete them, so renal failure, chronic kidney disease, CKD, or end-stage renal disease, so renal dysfunction. Second is potassium sparing diuretics. So when you administer the potassium sparing diuretics like spironolactone, that results in retaining potassium and hyperkalemia. Or sometimes patients develop the hyperkalemia from the increased intake of potassium or mobilization from the ICF. The potassium being mobilized from the ICF, like the tissue destruction and burn cases, or metabolic acidosis, and we'll explain about the metabolic acidosis and the hyperkalemia in the upcoming slides. The nursing implementation would be to treat hyperkalemia at 3 levels. The first lower level of hyperkalemia will be treated with diuretics, dialysis, caoxalate. And caoxalate is very effective in treating hyperkalemia because caoxalate is a resin and is going to be, so it comes in a liquid form, bottles of 15 grams, and other forms of the drug as well, other than the PO. But that's the most common one in the ED and emergency department patients will receive, one or two of these 15 grams bottles of brownish color liquid form, and they will, take in PO orally, and that will result in decreasing the potassium level in the blood, because that's a resin and it binds to the potassium in the GI tract and the release of potassium with the bowel movement. Now, the second level of management for hyperkalemia would be the IV insulin with glucose or sodium bicarbonate, because this will reverse the membrane So to treat the hyperkalemia, we said that the lower level of managing hyperkalemia is to give the diuretics or cakesalate. Second level is to force the potassium to be moved from the ECF to the ICF, from the blood vessels or plasma space inside the cells, by administering the IV insulin with the glucose or sodium bicarbonate. The third line of management, or the highest level of potassium, would be an extremely high potassium level to be treated with calcium gluconate IV. And the mechanism of action of the calcium gluconate IV is that the calcium ion can immediately reverse the effect of the depolarization of the cell excitability and fast movement of potassium will be pulled from the vascular space into the cells. So the manifestations of hyperkalemia would be the dysrhythmias and heart blocks like ventricular fibrillation, VFib, or cardiac standstill, which is like cardiac arrest, skeletal muscle twitching, fasciculations or weakness and paralysis, abdominal cramping and diarrhea, the hyperkalemia, an increased effect on the peristalsis, the GI tract, fatigue, prosthesia, which is like tingling sensation, and dyspnea. Hypokalemia, when the potassium level drops less than 3.5, causes that will result from increased aldosterone secretion, because the aldosterone functions to retain sodium and water and allow for potassium excretion. So more aldosterone means more potassium loss through the urine. Or because, hypokalemic cases or potassium drops less than 3.5 because of the high doses of potassium losing diuretics like loop diuretics, which result in the loss of potassium in the urine. Strenuous muscle activity and exercise also result in hypokalemia. Excessive use of the hypokalemia result in the decrease of potassium result in hypokalemia, or excessive loss of the potassium through the GI tract, like the diarrhea, vomiting through the GI loss. Manifestations, EKG changes, and its potential lethal ventricular dysrhythmias, like successive or recurrent or multiple PVCs. rapid, weak pulse rate, like tachycardia, an increased digoxin toxicity in patients or those taking the drug. So patients on digoxin and once they develop the hypokalemia, that potentiates and that will trigger the digoxin toxicity. So you have to maintain the potassium level within range for patients, for all patients, but especially if they take the digoxin toxicity, we have to monitor the digoxin level at the same time monitoring the potassium level as well. Decreased GI motility, which is paralytic ileus, due to the decreased peristalsis. Paresthesia, tingling sensation, decreased reflexes, the neurologic effect. Skeletal muscle weakness and paralysis due to the decreased potassium level. Because potassium, one of the functions of potassium is the transmission of and conduction of nerve impulses, and also the maintenance of the normal cardiac rhythm and skeletal muscle contraction. And muscle cell breakdown. And that's when there is a cell muscle breakdown, which leads to myoglobin in the plasma. So lots of myoglobin as a byproduct from that muscle breakdown, this myoglobin in the plasma, in the urine, and that will have a significant detrimental effect on the kidneys and result in renal failure, or what is called acute tubular necrosis, ATN, or renal failure from the muscle breakdown. Myoglobin accumulates in the plasma, excreted through the kidneys, and it will damage the kidneys tubules, resulting in kidney failure, and which is called rhabdomyolysis. This whole process is called rhabdomyolysis. Now, when we administer the drug, the potassium, we have to be very careful, is that this drug will never be administered through the IV push. Never given IV push. So this always should be diluted and not to exceed 10 milliequivalent an hour. So just the correction for this slide is that the therapeutic class, it is the drug for hypokalemia, not hyponatremia. Just correction for this slide. So again, we said that for potassium, that to never administer IV push or increased amount and not to exceed the IV rate of 10 milliequivalent an hour. And should be, very careful that this is causes burning sensation, and potassium is recommended to be administered by a large vein, central vein, not peripheral vein, because that's the causes burning and extravasation and infiltration, and it's burning sensation. So that's why it's highly recommended that we administer the potassium IV through a central vein. Calcium, which is mostly obtained from the ingested foods, more than 99% combined with phosphorus and concentrated in the skeletal system, in the bones and teeth. The bones readily available store of calcium. Most of the calcium is stored in the bones. Now, in a process called calcium resorption, means pulling the calcium out of the bones. We'll talk about this calcium resorption, which is when the calcium leaves the bone. That's due to the effect of PTH hormone, and we'll explain in the upcoming slides how the PTH hormone would function to maintain the calcium level. So the calcium is important for the transmission of nerve impulses, for the muscle and myocardial contractions, blood clotting, and formation of teeth and bone. What controls the calcium level within range? Three main controllers or three main substances like PTH hormone, calcitonin, vitamin D. So you have like two hormones and one vitamin, PTH, calcitonin, and vitamin D. Now, the hypercalcemia, when the patients had a calcium level which exceeded 11 milligrams per DL, that would result either from the hyperthyroidism because of the excessive release or production of the PTH hormone, or due to the malignancy, in which there is an increased cell division, and that will result in more calcium release, or when the patient ingests or takes a lot of vitamin D. So vitamin B toxicity or overdose can result or lead to hypercalcemia, or from a prolonged immobilization. In cases, for example, patients who are bedridden and they have limited or no activities, no exercise, no TT sessions or physical therapy or any type of movement, and even while in bed, that type of long-term immobilization that will result in that the PTH hormone is going to pull the calcium from the bone into the bloodstream. So that will result in the increased calcium being pulled from the bones, which is called calcium resorption or bone resorption. That calcium resorption, calcium being pulled from the blood, from the bones into the bloodstream, that will elevate the calcium in the bloodstream, leading to hypercalcemia. So prolonged immobilization will result in hypercalcemia because of that mechanism or that technique of or mechanism of calcium resorption, calcium being pulled from the bones into the vascular volume. The manifestations of hypercalcemia, the main danger of hypercalcemia, other than the EKG changes and neurological changes like decreased memory or confusion or personality changes, or being lethargic, or even the muscular, muscle weakness, or being depressed or decreased reflexes. Also, that the hypercalcemia can lead to because that's calcium accumulation in the kidneys mostly, in the blood, and then could result in more accumulation in the kidneys, can result in kidney stones. So renal stones is one of the main complications that could result from hypercalcemia. So the management of hypercalcemia, we treat that with loop diuretics like Lasix, give more fluids, hydration with isotonic saline infusion like normal saline or Ringer's lactate. You can give synthetic calcitonin to remove calcium from the blood or from the vascular volume, or mobilization, that activity. More mobilization is going to move or push that calcium back into the bones. So that's the mechanism of how the activity and mobilization and ambulation and the exercise going to push that calcium back into the bones from the blood vessels as a management for hypercalcemia. Now, the hypocalcemia, in which that the calcium level will drop less than 9 milligrams per DL. So what causes this hypocalcemia? Too many factors. The first one is the decreased PTH hormone production, parathyroid hormone production decreased. And we know that the PTH hormone is the main hormone responsible for to maintain the the calcium level in the blood. Another etiology for the hypocalcemia is the acute pancreatitis. And one of the manifestations of pancreatitis or the symptoms are fluid electrolyte imbalances like dehydration and hypocalcemia. Multiple drug transfusions, metabolic alkalosis, and decreased calcium intake. The manifestations tetany, which includes the muscle twitching, and two main forms of hypocalcemic signs. The first one is called the Chvostek sign, and the other one is Trousseau sign. And we explained in class the difference between these two signs, and we said that the Chvostek sign, that's the sign of hypocalcemia, in which the facial muscle will contract in response to the light tapping over the facial nerve in front of the ear. And the Trousseau sign, which is the carpal spasm, which will be induced by the inflation of the blood pressure cuff above the systolic pressure for a few minutes, and you see that the fingers will have what is called the carpal spasm in response to that inflation of that cough. So these two signs are positive for the hypocalcemia. In addition to that, given the function of the calcium, we anticipate that the hypocalcemia will lead to bleeding tendency, laryngeal stridor, and airway obstruction or breathing problems, and dysphagia, difficult swallowing, and numbness and tingling around the mouth and extremities due to that hypocalcemia. So it's usually treated with oral or IV calcium supplements. The protein imbalances, most of the proteins are, particularly the albumin, they are significant determinant of the plasma volume. And we explained that by, in the previous slides, explaining about the oncotic colloidal pressure and how these colloids, oncotic or colloidal pressure is gone, or proteins gone to pull the fluids back into the bloodstream to maintain the fluid volume in the plasma space. The hyperproteinemia, which is a rare condition, but that would result with dehydration-induced concentration. The hyperproteinemia would result from the high protein level, and which that's going to be what sometimes results from the TPN, maybe the excessive amount of protein intake has exceeded the normal range on like TPN, total parenteral nutrition, patient receiving the protein through the IV, and when they receive too much of that protein should result in hyperproteinemia. But the hypoproteinemia, that's more common than the hyperproteinemia, and it could result from either malnutrition, starvation, and an example of that would be also through hemorrhage or nephrotic syndrome. And nephrotic syndrome would usually develop in the children and pediatric. You will hear about this, in which that the patients affected by nephrotic syndrome, they will lose large amount of protein in the blood, 20 grams of protein, like 4 or 5 grams of protein would be lost in the urine daily, and that significant amount of protein loss in the urine, which results in generalized edema, swelling everywhere, especially the facial edema right around the eyes, and which is will be also here under clinical manifestation, says edema, slow healing, fatigue, ascites. These are the manifestations of hypoproteinemia. We manage that with high carbohydrates and high protein diet. And sometimes we have to administer the TPN, twisted parenteral nutrition. Acid-base balance. So under the acid-base balance, I believe that we discussed the three steps of systematic three steps of how to analyze or do the interpretation of the ABGs and how to analyze the arterial blood gases. And we provided several examples of that, and we recommended that students are going to practice more problems of these ABGs to be able to master the process of analyzing the arterial blood gases. So what regulates the ABGs, or the acids and bases, or the buffers and the kidneys and lungs.